ahead and hang up, and then you can watch the recording later. So, all right. Let me go ahead and turn off my camera, and I'm going to share. And I'm going to put this in presentation mode. And if Soda, if you would do me a favor and just watch the chat, if there are questions, then just let me know. Will that work for you?
Yep, doing.
All right. Thank you so much. Can everybody see my screen this time?
Yeah, it looks great, Stacy.
Thank you.
Yep.
So today we're going to talk about carbapenem-resistant Enterobacterales, which is better known as CRE. And this is really in the long-term care setting.
Stacy, I'm not sure if you're talking, but you are muted.
There I am.
Okay.
So, technical difficulties again. Sorry about that. So I just wanted to kind of talk about the CDC and their listing for organisms that are of great concern. And CRE has made that list and is considered a threat level urgent. Some other things, another one that's really in, concern for the United States is antibiotic resistant gonorrhea, which is another one that, if we lose our options for antibiotic for these certain organisms, we'll have no way to treat these infections. So. There we go. So, Enterobacterales are a gram-negative bacteria that you are commonly aware of. We see it all the time in people's lab results, especially in the elderly. E. coli is one of them. Klebsiella pneumoniae, Enterobacter cloacae, Serratia marcescens. These are all gram-negative bacteria that can be CREs. And carbapenems, or carbapenems, I should say, are the last line antibiotics that are used to treat serious multi-drug resistant infections. About 2 to 3% of Bacterales are associated with healthcare infections that are resistant to carbapenems. So we're not talking about a huge amount of numbers, but it is creeping up there. CRE infections do not respond to common antibiotics, so you can't just throw a simple antibiotic at them and they'll work. They are very invasive infections, and they are associated with very high rates of mortality. We call CREs that are resistant to all antibiotics as pan-resistant. So everything that we're testing this organism against will come back as resistant. Just in my own experience, I have seen individuals with pan resistance that were CRE that did pass away, and it was very sad. So there are a couple of carbapenem antibiotics that we use, and they're in healthcare settings. We don't really see them in long-term care settings, possibly, but not very often. And these are ertapenem, imipenem, and doripenem. And these are all IV antibiotics. So CRE is transmitted just like any other organism, can be direct or indirect contact with someone who's infected or someone who's colonized or on a contaminated surface. But in healthcare, it's mostly spread by people passing it on to the next person, usually by contaminated hands or by contaminated shared medical equipment. And in some instances, sinks and drains can be reservoirs of CRE. So this is kind of interesting, cool and scary at the same time. But there is carbapenemase producing CREs, and this subset of CREs basically are responsible for the rapid global spread of CREs that we're seeing, especially in healthcare settings. And carbapenemases are enzymes that inactivate carbapenem and beta-lactam antibiotics, making them unusable. But carbapenemase producing CREs can actually share their genetic code with other bacteria and make those bacteria resistant to carbapenems as well. And then there's a great graphic that the CDC put out, kind of puts it down into layman's terms. But basically, you have this bed of bacteria, and you have very few CREs in that sample. So you take an antibiotic and it kills off all of the organisms that are susceptible to that antibiotic. So now you have just this growth of CRE organisms. And to make matters worse, anything that's left over that wasn't or was susceptible to antibiotics but didn't die, the CRE will actually share that genetic code with that other bacteria and make them resistant as well. So it is a very scary mechanism. Interesting, but scary. So who's at risk? Patients, that are receiving complex medical care, and those residents living in long-term care facilities are at most risk for CRE and really any MDRO or multi-drug resistant organism. So people who have been critically ill in the hospital and those with invasive lines like urinary catheters, PICC lines, endotracheal tubes, anyone with a portal of access to their body is at risk. Anyone that requires daily assistance in bathing, dressing, and toileting. Anyone who has been on prolonged antibiotics, we know all of those people are susceptible to MDROs. Older adults and those who are immune suppressed, again, are at higher risk. Oop, sorry about that. Let me go back. There we go. And surprisingly, anyone who has been admitted to a hospital outside of the United States in the past 6 months. So colonization is a little bit different than infection, and we see this with all MDROs. It means that the CRE is on the body, but it's not causing illness. And people can be colonized with CRE for months, if not years. And that's where you see people repeating screenings of a resident to see if they're still colonized so they can take them off of special precautions. But again, sometimes you can see people who are colonized for years. It's really important that we recognize that colonized individuals are probably the biggest contributor to spreading disease. They don't have any signs of symptoms of illness, and they're not aware, for the most part, that they are colonized. And those who are colonized are at risk as well for being infected with CREs. CREs are an opportunistic bacteria. And so if you have that person who's got a wound, has lines that are placed, urinary tract, or urinary catheters, that type of thing, they are at risk. So I just wanted to show you some data that I came up with looking back through the state website. I only went back to 2021 and then 2023 to date. And if you look on this bottom column here, brown is this year, green is last year, and 2021 in the purple. We're really seeing some static numbers as far as those infected with CRE or colonized, one of the two. Of course, we're not done with 2023, so we'll see where that takes us. But for the most part, we're staying pretty static. And then I broke it into women and to men. Women lead the way just a little, but all in all, it's pretty 50-50. So. And then 60% of all the cases that were identified were over the age of 70. And 13% of all the cases, that were over 70 years reside in long-term care settings. So how is CRE reported? I get a lot of questions about, are we supposed to report this or not? So the state of Colorado made CRE reportable in 2012, and they were one of the first in the nations to do so. Good news is that all laboratories are required by law to report CRE positive lab results, and those reported labs go straight to the state. So they are getting those reports. But if you have a new CRE or you have a suspected CRE outbreak, that would be, 2 or more in your facility that are new, you need to report those as well. And most of the time, I would say that the lab already has that notification, but it never, hurts to err on caution and go ahead and report that. And I have that reporting data or those resources at the end of this presentation. Um, there's no harm in picking up the phone and just letting people know at the state or even with us that you've had a new case or you've had several new cases. And just as a side note, the state lab does have the capability to perform CR testing. Not all laboratories have that capability. So there's been a lot of debate on who's eligible for screening in long-term care facilities. And I think the state did do a presentation probably about a year or more ago about new screening guidelines for CRE and some of the others like CARPA and CRAB. But for CRE, we don't advise that long-term care facilities screen all new admissions. There's really no data to support that that's probably a good thing to do at this time. But again, this might change. But you should screen any admission that has had an overnight stay in a hospital outside the United States in the past 6 months. So that's really the one where you have to do that screening. So is there any questions so far? No? Okay, not hearing any. I'll move on. So how to decrease the risk of CRE in your facility? Most of these, are common sense. Hand hygiene is still your best measure. Using the alcohol-based hand sanitizer is just fine, or hand washing if your hands are visibly soiled before and after resident contact. And you're doing this anyways with all of your residents. And not forgetting to do hand hygiene for your resident as well. So assisting them with hand hygiene after toileting, after bathing, or during bathing, and before they eat is just as important as your staff cleaning their hands. cleaning and disinfecting shared medical equipment before and after use. If you have somebody who's colonized and you know that they're going to be in enhanced precautions for a good while, if you can dedicate that medical equipment to that person's room, that would probably be a good thing. But we understand that that's not always possible. So very diligent cleaning and disinfecting of your equipment is mandatory. We're going to talk a little bit more about enhanced barrier precautions in the next couple slides. And then participating in your antimicrobial stewardship program. I know that this is something that's been coming up in CMS as well. And this can really help drive your compliance with not using unnecessary antibiotics or limiting the use of antibiotics in your facility. The other thing you can do is to make sure that your lab actually can test for CRE. So if you need to get that test done, they can do it and they can do it quickly. Otherwise, you'll have to search around for a laboratory that does provide testing, or the state can provide that testing, but it is for a cost. I'm sure you probably already do this, but making sure that your admission forms for all of your long-term care residents include a history of MDRO infection or colonization. So, and this goes both ways. If you have somebody you need to transfer to a hospital who has CRE or any other MDRO infection, making sure that you're communicating that with your ambulance service and the receiving hospital. And don't forget to educate your families and your visitors about your program and enhance barrier precautions as well. So enhanced barrier precautions has been around for a couple years, and it's used for these, multi-drug resistant organisms of concern. That would be like crab, carpa, and CREs, but also others, ESBLs, MRSA, and the like. So what this just basically means is that you're going to use gown and gloves when staff are carrying out high touch activities. So if they're going in, they're doing bathing, they're doing toileting, they're doing dressing. These are things that you would anticipate that your staff would be in close contact with this individual, and they would have their clothing up and next to them, possibly getting contaminated skin to skin contact. I would say that the majority of whenever we're doing these types of activities, we have gloves on, but this is an extra layer of protection, not just for your other residents, but for your staff members who can become colonized themselves or even take this home. It's recommended that for any resident colonized or infected with an MDRO have enhanced barrier precautions. But it also can be used for residents who are at high risk for acquiring an MDRO as well. Those who have like indwelling lines that aren't going anywhere, just a chronic line, or people who have wounds. The big difference between enhanced barrier precautions and contact precautions is that a contact precautions room means that every time you enter that room, you will have on gown and gloves, and perhaps eye, protection. With enhanced barrier precautions, you're only doing this if you feel or you anticipate that you will be doing high touch activities with the resident. And this is really trying to balance the need for more protection with your staffing, and trying to decrease the need for PPE and just not overworking your staff with trying to protect the rest of your facility. And just like in standard precautions, whenever you anticipate, a certain risk in the room, if you um, anticipate that you will need eye protection due to splashes, especially like during bathing, that type of thing, you need to have that on as well. Any questions about enhanced barrier precautions? Okay. The CDC has actually come up with a sign, and I encourage you to get one of these signs off of the internet. It's a special color from the other, transmission-based precaution signs. Um, and it just really kind of just tells people what they have to do as far as entering the room. So they list out quite a few different things than I did. So just looking at those, and this is easily obtained on the internet, um, and it's free for use. But again, the nice things about this is you're only going to use your gloves and gowns during high contact resident care. You can do this in a room where you're sharing it with another person, but of course you would never use your gown and gloves with the one person and go to the next resident and take care of them. You always have to change. Take your PPE off, perform hand hygiene, and then go take care of the other resident. The nice thing also about this is that residents can participate in group activities, so they don't have that sense of isolation like they would if they were in contact precautions. And if your person is colonized for months, even years, this enhanced barrier precautions is intended to be used the entire length of the resident's stay. The CDC did come out with some couple of different questions that they've been getting a lot about, because I know it can be confusing to individuals, whether they need to do contact precautions and going in this room every single time, or if they need to just do enhanced precautions. It's just can be confusing, and especially for people who don't go in and out of the rooms more frequently than some other staff do. So in general, gowns and gloves would not be recommended when performing transfers in common areas like dining or activity rooms. And that's because they anticipate that contact will be shorter in duration. Um, is it perfect? No, but this does give the resident the opportunity to join activities and do dining room activities, and just really decreasing that sense of isolation. Um, Outside the residence room, enhanced precautions should be, followed when you're performing transfers or assisting during bathing in like the common shower rooms. Or if they're in a gym and your physical therapist is going to be up against this resident for a prolonged, matter of time, and especially, when they're assisting in those transfers and mobility. So those are some a couple things that they have gotten many questions about and wanted to pull those out for you to have those. The CDC has a great list of enhanced barrier precautions resources available. There, there are printable uh, guidance. There's letters that you can send to nursing home residents, family, friends, and volunteers. Um, you can print off information for your staff so they understand a little bit more about enhanced precautions. And there's even a training, an hour-long training on enhanced barrier precautions from the CDC as well. And I've checked these out, and they are all very helpful. And here are some resources basically for CREs in particular. The CDC, I put that in there. CDPHE has a healthcare acquired infection group, a team, and this is their uh, website. This is their phone number, and this is their email address. I've included 2 of their contacts, their EPI contacts. So if you have any questions about CRE, you have a new case, or you think you have an outbreak of CRE, you want to use this email address, this HAI_AR@state.co.us. It will definitely get to someone who is monitoring that mailbox, and they will return your phone call. If you have any questions about it, or still not, completely sure who you should take that to at the state, I put my own email address in here and my office phone number if you have questions, and I can help steer you in the right direction and get the right people from the state to return your phone calls. So that's really all I have. Let's see here. Try to get back here. All right. So I'm going to open it up to questions, see if anybody has any questions for me at this time. If I don't have any questions, that means I did a rock star job. And really, that's all I have on CREs today. Just a plug in for your COVID booster vaccines are coming, available here in the next week. So please take advantage, get your residents vaccinated. Flu vaccine is available. Your RSV vaccines for older adults are available. And just a plug in for you to get those done for your residents and your staff. Not the RSV, but the others for your staff. If you don't have any other questions, I will let you take your the rest of your lunch break, and we'll have our next information session next month. Let me look at the date. On the 16th of October. So, and Michelle, yes, let me know, keep me informed with your Kaiser problem. So, all right, guys, you have a great day, and I will talk to you next month.
Thanks, Stacy.
Thank you.
Good job, Stacy.
Thank you.